Thanks, everyone. We actually had a couple of questions submitted ahead of time. So while my ushers are collecting the questions, I have a couple here. Dr. Scally, I have a concerning growth or mole. How can I come see you, and how long will a referral take?
That's an excellent question. So basically, everyone should take a look at their own skin on a regular basis. If there's something that you see that you don't remember seeing before, you're worried about, it's been painful, it's bleeding, you should go and see your family doctor first. And if they agree, or sometimes they know what it is and can deal with it, but if not, they can send a referral to us. Suspicious lesions are something that my office triages. We're trying to get urgents in, within a month. But it's really important that it's flagged on the referral, or we can't tell. So if you're really worried about something and you really feel that it's going to be too long till you see me, it doesn't hurt to call my office. Okay, that's pretty much it. Perfect. So the timing really depends. We try and do it within a month.
Thank you. And Dr. Coldebaran, does the lab at Sechelt Hospital process and report on your biopsies, or does it have to be sent away as well?
No, they have to go to Lions Gate. As I said, the wait time is about 2 to 3 weeks. It's not that much different, I think, if you were in Vancouver in terms of wait times. It's more a matter of the volume that they have to deal with. And actually, recently, we've been getting the results a little bit faster. It used to be 3 weeks right after the pandemic, and I think maybe the backlog is reducing. So now it's about 2 weeks and sometimes even less.
This is a sunscreen one. Is sunscreen that's quickly absorbed into skin more or less effective than sunscreen that stays on the skin surface? Dr. Scally?
So I guess if we look at the mineral sunscreens, they used to be really cosmetically unappealing. They were very white, and so they would stay on your skin and you'd see them for a long time. Now they're micronizing them and they're making them much more cosmetically acceptable, so they absorb quicker. So no, I would say just because it absorbs quicker doesn't mean it's any less effective. So base it on the SPF on the bottle.
Okay, a related question. My daily face moisturizer has an SPF of 30. Do I still need to use sunscreen over top daily, i.e. face lotion SPF 30 plus face sunscreen SPF 45? In addition to above, if I use both, is it good, or should SPF 60 just be way better? If I got that question, I hope.
Okay, I hope I answer it properly then. So the first one about daily moisturizer and SPF 30. So it's really important, remember what I said about the amounts you're applying. So most people only put 50% on the amount of sunscreen that you're supposed to, based on the studies where they design the SPF, which are actually using really not normal amounts. So if you're putting a light layer on of a daily moisturizer that's SPF 30, you're probably not getting a 30, you're probably getting a 10 to 15. So yeah, you probably should either most people don't want to do 5 steps as well. What would be easier in the summer is just to put a sunscreen on instead. That's a 60.
Okay, great. Dr. Coldebaran, what's the difference between chemotherapy and immunotherapy, and who prescribes immunotherapy? Is it a specialist?
So immunotherapy, the way it works is it actually activates your own immune system to kill the cancer cells, whereas cytotoxic chemotherapy is toxic to all cells, but more so to cancer cells. So immunotherapy can have a lower side effect profile and be a little bit more specific. You have to go see an oncologist at BC Cancer Agency to get the immunotherapy, but although it is, I think it is done locally in Sechelt. We have internal medicine specialists who work with oncologists, and they can administer those medications locally in Sechelt.
Okay, great. And once you've had a basal cell carcinoma and a lesion removed, are they more likely,
More likely to
I guess, reoccur?
recur? No, I mean, if you had negative margins, they rarely return. I mean, part of it is how long it takes. I mean, sometimes, it depends how long you follow the patients. And that's something that's sometimes hard to study, because a lot of studies, they look at 5 years. And, if you've had negative margins, then the chance of it coming back is very low. You can also get new cancers. I mean, sometimes people have a lesion removed from their nose and then get another one. And, it may not be exactly in the scar of the excision. So they can return, but if you've had negative margins, the chances are very low, but you can also get new ones. Would you agree, Dr. Scally?
Yes, I think it's really low chance of it recurring if it's been removed with negative margins. But the chance of getting new basal cells is 40 to 50%. So it's quite high.
Okay, I was quite shocked to hear about the white T-shirts being useless, so that's sad. Thank you. Someone else in the audience said, I heard blue clothing protects you from UV rays. If you cannot see through your clothing, can the UV rays still penetrate to the sun?
Yeah, I think that's a great question, actually. So they say you can hold your clothing up to the light and see how much light gets through, can give you an indication of how good the protection is. It depends on the fabric, like how tight the weave is and what the material is. And also dark is better than white. So the dark color absorbs UV rays better than white. But you're better off just getting the UPF labeled clothing, and then you don't really need to worry about it.
Okay, this might be predating you, but has UVA, UVB radiation increased with climate change? Is the sun more dangerous now than it was 50 years ago?
So I don't know if I can fully answer that properly, but like when there was issues with the ozone layer in certain areas, they definitely saw an increasing UV intensity in skin cancer, but a lot of that has been resolved now with changes in emissions. So yeah, that's probably all I can really say.
I thank my colleague here, Brenda Rowe, who's curating questions for me here on the fly. When is laser therapy used? Or is it? Is it such a thing?
For what, the skin cancers? Or-
Yes.
It's not really used, no.
Okay, thank you. Okay. If you will be sweating a lot, is it worth to put sunscreen on? What if you forget to put sunscreen on first? Will the sunscreen just sweat out of the skin?
Yeah, I mean, if you're sweating actively, like say if you're putting sunscreen on and you have sweat on you, you're going to get a dilution of it. So it's definitely not going to be that effective. Ideally, you apply it to dry skin, and then if you start sweating, yeah, you need to reapply it. But if this is an area of the body that you can just put hats or clothing, if this is a problem because you sweat a lot, it's probably easier, a UPF hat or clothing.
Okay, if I find that some local doctors do not recognize precancer spots when you see them, or do not take them seriously, no treatment is given and no referrals, what to do in this case? And how long should I wait if I see something suspicious on a skin spot, or determining when I could get an appointment? Hot topic.
Yeah.
Sorry.
I mean, the first step of getting to us is through your family doctor. Maybe I would approach them again and say that you're really worried about this and you would just be more comfortable having another opinion. Or see another doctor, another family doctor, and try and get a referral. But if you highlight that you're very worried about it, maybe that would they'd be more easily give a referral to us then, I suppose.
I just want to add something to that because, my approach to these things is that, everybody's clinical judgment is different. Dr. Scalia's clinical judgment is way better than mine. My own clinical judgment has changed since I started practice just by experience. And so my approach is I either know if something is benign or something is suspicious. And if I don't know, I can always do a biopsy or a small punch biopsy, and then you get a more definitive diagnosis. If you've had a biopsy and it's not cancerous, the chances of it being cancerous is very low. We never ignore lesions, though. We always say, observe them, because lesions can change. Like an actinic keratosis, like you were saying, can turn into a squamous cell carcinoma. So observation is part of it. But again, if I'm not sure if something is cancerous and if the patient is concerned, probably the easiest way to deal with that is to do a biopsy and you get a more definitive diagnosis.
Okay. That's essentially questions from the crowd so far, but while we're here, okay, keep going. Sure.
I have two questions. Dr. Colburn, is that radical, sort of dramatic edema always a side effect of the lymph node treatment removal after a melanoma?
Oh, so I think you're talking about lymphedema.
The huge,
Lymphedema has a much lower rate after sentinel lymph node biopsy because we're only removing 1 or 2 lymph nodes. The dramatic lymphedema that people used to get, particularly with breast cancer, is when remove all the lymph nodes. And these days we rarely do that. For example, for melanoma, it used to be that if you had a positive sentinel lymph node, you had to go back and remove all the lymph nodes. We don't always do that anymore because immunotherapy is getting so good. So the rate of lymphedema with sentinel lymph node biopsy is very low. It's not 0, but it's very low. And even if it happens, it's not as dramatic as what people used to get.
Great, thank you. Dr. Scalia, I also have a question about associated professional healthcare type people, practitioners that see our skin more so than we do. I don't see my own back very often, but the massage therapist does. Is there an education program for those kinds of practitioners? Because they seem to me to be the first line of defense for most of us, because you might go for a massage or a chiropractic treatment and they might say, you've got something on your back, I think you should get looked at. Is there any kind of formal education for those types of practitioners?
Yeah, that's really important because a lot of the people I see, they'll say to me, my RMT said that I should get this spot checked out on my back. Not that I know of, I don't think there is. I think everyone could use more education in skin, like everyone, all the allied health professionals, family doctors, but there isn't any existing that I know of unless they're doing it themselves on their own. Like CDA has a great website where they educate on similar to what I talked about, the most common skin lesions. So they would probably have to be doing it on their own.
And how do you feel about some of those apps on your phone?
I don't use any apps.
Because there are so many skin apps
I know.
on the phone.
The problem is, though, none of them have been proven to be better than your eye, like our clinical judgment, or the patient being worried about something, and then we look at it, we do a biopsy if we agree. So none of those, and they can give you a false sense of security. And also, I think they probably lead to a higher biopsy rate. So that in itself can pose a lot of unnecessary surgery. So I don't use them. Like if I see a mole I'm worried about, actually I take a photo on my phone, it goes straight to the EMR, and the quality is amazing. And then if I don't feel it needs to be biopsied, I'll bring them back and look at it again. So I just take photos.
Great, thank you. How many of you have got something on your skin that you're concerned about right now? Okay, yeah, that's quite a few then. So the advice for people that are worried, just to reiterate it, I know you've given it, but
go see your family doctor and let them take a look first. And sometimes they can tell you what it is. It's very common. I think every day I talk about age spots. These are spots that come on. We all get them. You see them in 30-year-olds as well. And they're a really common referral. And, often the family doctors, if it's one of those, because they come on with age and they're growing, they can often answer the question. But if they're not sure, they'll refer on to me or another dermatologist.
Wonderful, thank you.
Can I just add one more thing about the photo? I think it's a very good point. I think you can take a photo of your own skin lesions as well, and it's very useful because it's there, and then you can compare it later on to see if a skin lesion has changed. The other time that it's very useful for me is that sometimes people have a skin lesion removed, and then the biopsy comes back 2 to 3 weeks later showing cancer, but the scar has faded, and it's very difficult to say where that lesion was. But if we have a photo, then that helps me know where that is. If I can't find the scar, I cannot do a wide local excision. So take a photo if you have a lesion that you're concerned about, even if it's going to be removed. As a matter of fact, it's probably better to take a photo if it is going to be removed.